Why don't we begin? I'm going to welcome you all to this first panel of this year's Urban Research Day on the topic of health. My name is Jo Boffard. I'm the clinical professor of global health at the NYU School of Global Public Health and a member of the faculty advisory group for the University Initiative on Urban. And I want to thank Sherry Gleed for her leadership of that group, and also Raquel Forrester for making all of everything we do possible, really. I'm very happy that this panel, to be here moderating this panel on health. And I would say that the word health is in this panel, but in reality, if you take a very broad view of the determinants of urban health, virtually every topic that's being discussed on the other panels today is potentially a positive or negative impact on health or determinant of health. So, and health equity for that matter. So even if the word health isn't there, when we think broadly, we're concerned about these other sectors and the decisions that are made in those sectors. I'm also delighted to moderate this diverse panel of scholars, which I think really epitomize the interdisciplinary nature of urban and urban health research, and also the importance of mixed methods approaches, both quantitative and qualitative, to this work. Our faculty among them for this panel are associated with the School of Global Public Health at the Marin Institute at the Law School, with the Medical School, and the Engineering School with the CUS program. So I think they really represent people who are working across boundaries. And it's a challenge for interdisciplinary scholarship in any university. So I want to congratulate NYU for its support for such an effort. The run of show is as follows. We'll start with individual presentations by our speakers, followed by a facilitated discussion. And then we'll do questions and answers for a period of time. And if at the end we sort of run out of the organized questions and answers, we can have a breakout so people can have an informal opportunity to speak to each other. I want to make sure, do we have Sally? All I'm seeing is the slides, Raquel, so. Can I see the speakers? I guess maybe we don't have him yet. Okay. At any rate, the speakers are grouped in a sort of two groups. Well, the first three speakers are really specifically talking about COVID, and the second are talking about issues that are sort of related to COVID, but not explicitly on that topic. I think COVID has been such a dominant theme in any health conversation over the past 14 months or so. And importantly, while the elements of the disease itself have been important to all of us, for people working in the urban space, COVID has really revealed significant disparities in multiple sectors in cities that we all knew were there in terms of housing, economic development, issues of transportation, and overall environment. What we are hoping, I think many are hoping, that the fact that more opinion leaders, more elected officials, more of the public in general have really been thinking about the issues of cities and the issues that have been revealed by COVID in cities. There's a real opportunity perhaps to begin to act to address some of the problems that have been identified. So our first three speakers, and if I don't see the first one, I was going to say, are really, as I said, specifically talking about COVID, starting at the city level. Shlomo Angel, professor of city planning and director of urban expansion at the Marin Institute of Urban Management. Our second speaker is looking at COVID at the neighborhood level, and his name is Constantine Kontokosta, who's the associate professor of urban science and planning at the Marin Institute and director of the Urban Intelligence Lab. And he's associated with CUSP at the School of Engineering, which I want to mention. And finally, really looking at COVID at the individual level, Dr. Emily Goldmann, who is clinical associate professor of the Department of Epidemiology at the School of Global Public Health. So we'll go from sort of the 15,000 foot level to the neighborhood level to the individual level, looking at the impact of COVID and some really important investigations colleagues have been doing. And then our last two speakers will be really focusing on one of the issues that you'll see in Dr. Goldmann's slides is that food is a major preoccupation of individuals and availability of food. We've seen it in the press and the news. And so our last two speakers are going to be talking about issues of food, nutrition, food systems, and some of the challenges both in the marketing, the processing of food and the marketing of food, and the risk factors for these foods in terms of the chronic diseases that have certainly raised the likelihood of individuals being more susceptible to COVID. So Professor Niyati Parekh, who is Associate Professor of Public Health Nutrition at the NYU School of Global Health and affiliated with the Grossman School of Medicine at NYU, and Filippa Juul, who is an NYU Provost Postdoctoral Fellow at the School of Global Public Health, will be speaking on those topics. We've asked each speaker to speak about 5 minutes. I'll be watching the clock and signaling. Then, as I said, we'll have a sort of structured Q&A followed by an open Q&A. So I think you put your questions in the chat box, Raquel, or send them to Raquel, and she'll help curate them as they come in. So not seeing Solly, I think we will, oh, there he is. Ha, you're on my other screen. Great to see you. All right, Dr. Angel will begin our presentations, and we'll tee up his slides, and we'll go in the order I mentioned. Solly, you're on.
I'm on. Yes. Is my presentation on?
It should be.
Okay.
It's probably the next slide. Raquel?
The next slide.
Yes.
Thank you very much. I had trouble logging on. This is going to be a short 5-minute presentation, and it deals with an interesting policy problem, and that is urban planners have been advocating densification and increased density as a cure for a host of urban ills, from excessive sprawl to currently, cut down greenhouse gas emissions, because higher densities means more people can use public transport, more people can bike and walk, and less use of car and less vehicle miles traveled. And now with COVID, there's been kind of a backlash on density, because people feel that density, kind of bringing people into close proximity, endangers them. And so this paper is about refining this issue and saying, well, the urban density that we care about, which is the average density of cities, like the total population divided by their total area, actually does not have a negative effect on COVID-19 cases. And what that so what we're saying here, there is a population effect, and namely, I can't get the next slide. How do I get the next slide?
Just call for them, right. And Raquel will slide.
So we want to show that the population does affect city COVID-19 infections and deaths, and larger cities do have more than their share of reported cases and deaths, but denser cities don't. This study is a longitudinal study of 20 weeks of the pandemic, focusing on US metropolitan areas. So next slide. We look at the population of a metropolitan area and the urbanized area of cities. And here we show Chicago and Atlanta. The urbanized area means the area where people live, not just the county that they live in. Next slide. There is a clear relationship between the total number of cases and population. Here it's on log scale on the left. You can see that it has a very strong R-square, 0.77, a slightly weaker one on the right for deaths. But it's very clear that both cases and deaths relate to population. Next slide. They also relate to area, but in a different way. Now, the relationship between density and the reason that we can't study density and COVID is because density is also affected by population. Namely, larger cities have higher densities. And because of that, it confuses the relationship between density and the pandemic. So we have to separate area and population. So we see that there is also a relationship slightly different between COVID-19 and the area of cities. You know, the larger the area, the more cases, the larger the area, the more deaths. Next slide. When we look at the kind of the multiplier of COVID-19 cases and deaths with population and with urbanized area and with density, we see that over a 20-week period, they stabilize. And when they stabilize, we can see what the relationship is to density. And the one on the left shows cases, and it shows cases stabilizing with urbanized areas having more cases than population. And then the same with deaths. We can see that urbanized areas have more cases than population over time. Next slide. So that says to me that what we find is during the last 10 weeks, ending in July 23rd, the numbers tended to converge. City with double the population can be expected to have 17% more cases per capita and 28% more deaths per capita than the smallest city. But the city with double the density of a smaller one can be expected to have 4.1% fewer cases per capita and 7.4% fewer deaths per capita than the smallest city. So what we then cities with the lower density. So that means density has the opposite effect of population. And we shouldn't worry about density affecting COVID-19 cases, but about populations. Last slide. So larger cities have more than their share of cases and deaths, in part because the larger the city, the larger the number of possible interactions among its inhabitants. And it is this larger number, rather than the overall average proximity of people to each other expressed by the average density in the city, that accounts for that larger share. In fact, when it pertains to COVID-19 cases and deaths, denser metropolitan areas appear to be better able to contain their numbers than more spread out ones. Thank you.
Okay, perfect. Right on time. Great role model for everybody else. So we'll move on to Professor Kontokosta, looking at the neighborhood level.
Great, thank you. It's great to be here and great to follow Sali in his excellent work on the topic. I wanted to spend a few minutes just talking about our work using large-scale geolocation data to really understand mobility behaviors, both at the micro and macro scale within cities and how that relates to COVID infection risk. We're particularly interested in understanding the heterogeneous effects of neighborhoods on outcomes, because we know that even within a specific city, the various aspects of social determinants of health, of population health indicators, other measures can influence infection risk and, of course, infection outcomes. So we want to understand one specific measure of that right now, which is understanding something we've developed, which is called exposure density, which is essentially a real-time dynamic population density measure at a very, very high spatial resolution, at 250-meter grid resolution across the city, and wanted to see how individual behaviors and mobility behaviors across different neighborhoods changed before and after the stay-at-home order in New York City, and then ultimately what the effects of those changes were on infection risk and outcomes. So next slide, please. So our data are being pulled from a large scale, as I mentioned, a large scale provider of cell phone related geolocation data. It's a national sample that's covering multiple years. We have most of 2020 covered. In total, we have about 20% of New York City, information on about 20% of those in New York City during this time. So essentially what we were looking at was the pre and post periods before the stay-at-home order, so late February, and then after the stay-at-home order, the New York on pause. And we essentially measure this exposure density as the density of people outside of residential areas. So we actually are combining this geolocation data with land use data, and I'll talk more about that in a second, to get this more real-time measure of what is the probability of two people coming in contact, or a group of people being in contact. Now we're aggregating and anonymizing these data such that we're not tracking individuals, but we're looking at grid cell or kind of spatial aggregations and temporal aggregations over time. And this gives us a lot of flexibility to also be able to adjust the unit of interest. So whether we're talking about census tracts or neighborhoods, or in this case, we're talking about zip codes, because that's where the COVID data relates from. So we measure this exposure density as the change in activity across these different land use categories. So residential, non-residential, and outdoor. And then also a volume change and a proportion change. So how activity might be shifting from one land use classification to the other. So people staying at home more often, for instance, as well as people actually leaving the area. And that was obviously a major issue in many major cities, continues to be, that we're interested in. And looking at how population density, of course, is not static, and trying to see how migration patterns or pandemic-induced migration patterns might change across different neighborhoods, across different regions. So this work is actually forthcoming. You could read a bit more about it in the Proceedings of the National Academy of Sciences. It should be out in a week or two. And essentially, what we're calculating these exposure density metrics for every zip code in the city, and then we're clustering to find neighborhoods that share common mobility patterns. And those clusters are shown on the right in the different colors here. And you could see the kind of time series of activity in the plots below. What we find, controlling for many other factors, is that exposure density is an important consideration in terms of looking at the overall effect on positivity rate in particular, which is a unit of measure that we're concerned with, an indicator we're most concerned with. And also find that, there's significant differences in, say, below 96th Street in Manhattan, where we have a very large decrease, almost 44% decrease in exposure density, that's driven both by people staying at home and people leaving the city, compared to some of the poor predominantly minority areas where exposure density stays more constant. And this is, we presume, largely because people still have to continue with their daily commutes, continue to go to work in essential services, and we're less able to actually change those behavior patterns in response to the stay-at-home order. Overall, we find that if the lower income and predominantly minority neighborhoods were able to change their exposure densities by as much as the wealthier neighborhoods, between the start of the pandemic and beginning of June in New York City, several thousand, almost 2,000 lives could have been saved in those lower income neighborhoods. So this is kind of an important next component in thinking about how do we understand on a very dynamic basis how cities are changing, how neighborhoods are changing, and how social distancing, for instance, is affecting different neighborhoods in different ways. Next slide, please. Now, an important consideration of this is the massive scale of these data, and then we thank the CUSP Research Computing Facility and NYU HPC for their assistance and their infrastructure in making all of this possible. But we're using not only the mobility data, but connecting that to road network data, to even as high resolution as sidewalk level data, looking at different types of land use categorizations at a very high resolution. And we've done this now for 20 different cities where we also have COVID infection data at the zip code level. And so we've expanded this study from just New York to now looking at comparisons across different cities. And we're able to integrate these and then ask and answer a lot of very interesting questions, I think, about activity patterns that go beyond just our interest in COVID specifically. This gets into a lot of issues around the built environment and the effects of the built environment on various measures of individual and collective outcomes. So next slide, please. So part of the work that we're doing now is actually using network analysis to better understand these mobility patterns in terms of how commute patterns and broader macro patterns change as well. So this is work that's coming out in Nature Communications that we just finished up. This is looking at evacuation patterns in response to Hurricane Harvey in Houston, Texas in 2017. But we're using a similar methodology now to understand how pandemic-induced migration patterns affect different neighborhoods differently. So how do we see, for instance, a neighborhood's typical commute pattern? How does that change over the course of the pandemic? And then we're hearing so much, of course, about people fleeing out of the cities and kind of where people are going and how permanent are those shifts. And then, of course, trying to understand disparities underlying the ability to change behavior and how those mobility patterns might change over time. So these are some examples of some of the ways we're using these data right now for this, in particular, this NSF-funded COVID work. But now we're extending this into several other studies that are more national in scale, macro in scale. So thank you very much.
Thank you very much. And our next speaker in this cycle is Professor Emily Goldmann of the School of Public Health, and she'll be talking really at the individual level. I think it'll be interesting to get the insights in relation to looking at place from a high level and in the neighborhood stage. So Emily?
Thanks so much, and I really appreciate the opportunity to be here and talk about some of this current work and to hear what others are working on. I'm going to take us actually back to Houston in a small way, and I wanted to thank Raquel very much for putting this all together, but also apologize profusely because I over-animated these slides. So I'm going to ask her very kindly to do a lot of clicking for me. So if I say click, if you could kindly click forward. And again, my apologies. I think I get too excited about PowerPoint animation capability. So bear with me. Next slide, please. So, as we all well know, the COVID-19 pandemic has had a profound impact on mental health globally, but also in the US. And it's really being driven, our thoughts are, it's being driven by the extreme uncertainty around the end of this pandemic. When are we going to get vaccinated? What's going on? As well as the extreme stressors that people have been going through related to the pandemic. We've also noted quite a bit of discrimination and an increase in hate attacks against certain racial and ethnic minority groups related to the pandemic. And that's what initially drove this study, to try to understand racial and ethnic discrimination around COVID-19, the experience of other COVID-related stressors, and its impact on mental health. And we were very fortunate to have the opportunity to work on what we're calling the COVID-19 Southern Cities Study. And this is a big survey that we conducted, a group of researchers at the School of Global Public Health, along with colleagues at Johns Hopkins University, Bloomberg School of Public Health, as well as individuals at the University of Texas at Tyler. So we put out a web-based and random digit dial telephone survey at the end of May and early June that included over 1,700 adults who resided in 5 different metropolitan statistical areas of the South. And Raquel, if you could click forward, that you can see here, thank you. They include Dallas, Austin, Houston, New Orleans, and Atlanta. And our thought was to focus on southern cities, one, because these areas get a little bit less attention, or were getting a bit less attention at that time during the pandemic. They were at a different trajectory in terms of infection, hospitalization, and death compared to New York when we were putting the study together. But most importantly, this is an area of increased racial polarization, more immigration from the South, as well as a very, very unfortunate recent strong history of disaster experience. So through things like Hurricane Harvey and other hurricanes. So this is a population that's experienced quite a bit of disaster. And we can think of the COVID-19 pandemic as a disaster in itself. We oversampled by race ethnicity so that we could really dial down into the experience of specific racial and ethnic groups. But we also ended up in developing and using weights to try to make our sample representative of these 5 metropolitan statistical areas. Click, please. So I want to talk about our the first analysis, the first paper that we were working on out of the study that we are just about to submit for publication, and we're excited to present at some conferences coming up. And this was a look at racial and ethnic disparities in mental health in the US South during COVID. So this included 1,688 individuals in 4 racial ethnic groups. And this doesn't include every single person in the study because some people declined to give their race ethnicity or were in a smaller group. And the group was too small to use as a category, but it includes non-Hispanic white, non-Hispanic Black, Hispanic, and non-Hispanic Asian respondents. We were really interested in the experience, as I said, of COVID-related stressors. And we already know that racial and ethnic minority groups are experiencing greater stressor experience during COVID-19. And the question is does this translate into worse mental health outcomes for these groups as well? We already know that these groups are additionally experiencing worse COVID-related outcomes in terms of infection, severity, hospitalization, and mortality, but we wanted to see if this was translating into mental health disparities. We looked at COVID-related stressors, including past month's shortage of money for food for the household, being an essential or frontline worker or having one in your household, how many people you've known with COVID-19, so more than 0 or more than 1 at the time it was less common, and isolating even without symptoms, trying to get at that aspect of lack of in-person social interaction. Then we looked at 4 different mental health indicators. Past week probable depressive or anxiety disorder measured by the Patient Health Questionnaire 2 and the Generalized Anxiety Disorder 2 scale. These are both 2 screening instruments for depressive and anxiety symptoms, respectively, as well as past week hyperarousal or sort of physical reactions associated with thinking about COVID. This is a symptom of post-traumatic stress. This is not a measure of post-traumatic stress disorder, but rather a symptom of a screener to get at one symptom of it. Past week trouble sleeping and worsened mental health since the pandemic began. And we use complex survey procedures to do the analysis. Next slide, please. So just to focus first on the prevalence of COVID-related stressors by race ethnicity, you can see the percentages overall at the top. So you can see that between 1/4 and 1/3 of the entire sample experienced these types of COVID-related stressors, the most common being knowing someone with COVID, shortage of money for food and being an essential worker. But you can see that there are some significant differences by race ethnicity, and specifically Hispanic and non-Hispanic Black respondents who are in red and in green, respectively here, have reported a significantly higher prevalence of being an essential worker, having an essential worker in their household, and knowing somebody with COVID-19. So having these additional stressors and additionally having shortage of money for food. Click, please. The question is then, does this translate into greater prevalence of mental health conditions? And by a large part, it does not. So we do see slightly higher prevalence of depression, of trouble sleeping, of worsened mental health in non-Hispanic Black and Hispanic groups. We see, particularly for hyperarousal, we see an increased prevalence for non-Hispanic Black and Hispanic respondents, but the only significant association at the bivariable level was hyperarousal. But of course, there are factors that are associated with race ethnicity and also risk factors for mental health, we call them confounders, that need to be accounted for. Next slide, please.
1 minute, Emily.
Perfect. And this is our bunch of different models looking at our different mental health outcomes. And if you could just click one more time, Raquel, for me, and I promise that's the last one. I just want to highlight the significant findings that come out of our adjusted models. We first adjusted for basic sociodemographic characteristics, previous mental health conditions, and self-rated general health. So these sort of basic confounders. And then in our third model, we additionally controlled for this experience of COVID-related stressors. And interestingly, for most groups, we find no difference by race ethnicity in these mental health outcomes, but for some, including probable depression or anxiety, probable anxiety on its own, and worsened mental or emotional health, we actually find significantly lower odds of these mental health indicators among non-Hispanic Black versus non-Hispanic white respondents. And this is actually quite consistent with previous literature around differences in these mental health indicators by race ethnicity, and what's been found so far in the COVID-related literature. And this may have to do with increased resilience in these groups, increased amounts of social support, or methodological issues around whether we're really capturing the full spectrum of distress in these different groups. And that's something that we talk a bit in terms of the limitations. I will stop there, but I look forward to questions. Thank you.
Okay, thanks very much. That's terrific. All right, we're going to segue into looking at the broader area of nutrition, food systems, quality of food, which is a little bit different. And I don't want to artificially link it to COVID, but I think all of us are concerned about the risk factors for non-communicable diseases, which were quite visible also during the COVID epidemic. So let's start with Professor Parekh.
Thank you and good afternoon. It's a pleasure to present in this forum today. My work investigates dietary risk factors of obesity, cancer, and CVD in large epidemiologic studies, including the NHANES and Framingham Heart Study cohort, among others. So I'll present my cumulative work and how it fits into the framework of commercial determinants rather than one study. So for instance, I've investigated carbohydrate nutrition, as you can see on this slide, in relation to non-communicable diseases of all sorts that you can see at the bottom. Carbohydrate sources include fruits, vegetables, and whole grains on one end of the spectrum to sugary drinks and beverages at the other end. I've also investigated dietary quality, which is assessed by scores computed from reported diets by study participants. I evaluate food insecurity, which by definition accounts for both quality and quantity of foods. And food insecurity is closely linked with the intake of cheap, industrially mass-processed foods. So taken together, evidence from my own studies and the larger literature suggests sugary foods and ultra-processed foods are associated generally with poor health outcomes and these diseases. My work has exposed cracks in the food system and has implications for our food environment. My work largely points to industrial foods being the culprit, a topic that you will hear a little bit more about in the next presentation by Filippa. Next, please, and 2 clicks. One more. So this brings me to the commercial determinants of health. And what are they? They're determinants that stem from the profit motive, often described as strategies and approaches used by the private sector to promote products and choices that are detrimental to health. In the case of food, corporates determine the availability, promotion, and pricing of unhealthy products that are omnipresent. These determinants have become particularly relevant because deaths from non-communicable diseases accounts for approximately 80% of all deaths globally. This is also relevant to COVID, by the way, because in a separate study, but we looked at the pandemic pantry, we did see that people were mostly stocking ultra-processed foods. So there's your COVID link. Next slide, please. So here is my favorite example. This is pink washing. The alcohol industry is very strong, and there's convincing evidence by international authorities on cancer risk factors, such as the World Cancer Research Fund, on the causal links. And the word causal is not to be taken lightly, but there's causal links between cancer and alcohol, and yet it has been used as a successful marketing strategy. And little is known about its cancer-causing potentials within the general public. Next, please. So this slide shows 4 key pathways by which corporations influence the environment and subsequently human health. Marketing and lobbying are good examples. Select data are available. For instance, Coca-Cola, Pepsi, and the American Beverage Association spend a total of about $115 million on lobbying at the federal level between 2009 and 2015. Corporates invest in distribution systems, such as trucks, and sometimes they lay down roads in rural areas. They invest in supermarkets and delivery mechanisms, and this is called as the phenomenon called supermarketization. These can actually change cultural norms and normalize purchasing and other types of behaviors. To end, I'd like to say that thus far, we have focused on modifiable and behavioral risk factors, such as tobacco use, unhealthy diets, which, they've probably made a small difference, but they've not moved the needle too much on non-communicable diseases. The commercial determinants of health approach bridges research and policy silos that divide different diseases, population groups, and types of interventions. This concept promises a more holistic, integrated, and targeted approach, and it also suggests how we can join forces as scholars by organizing our research under this broad umbrella of commercial determinants. I'll end with that. Thank you.
Great, thank you. Perfect. Thanks so much, Niyati. And now our last speaker, Filippa Juul, continuing the conversation on quality of food and its risk factors associated. Niyati, or Filippa?
Yes, thank you so much for having me here today. So I will dig a little deeper into what Niyati called ultra-processed food and food processing level. And I can't see my slides. There we go.
There we go.
Perfect. Yes, so I'm going to present regarding trends in food processing level in the US diet from 2001 to 2018, which is a study that I'm doing with Dr. Niyati Parekh, Dr. Virginia Chang at GPH, and also in collaboration with the University of Sao Paulo in Brazil. So nutritional surveillance is essential to inform efforts to improve diet and prevent diseases. We need to know what the population is consuming and how it changes over time, with, of course, special attention to disparities and health disparities in both diet quality and chronic diseases. So until now, nutritional surveillance has largely focused on nutrients or food groups such as whole grains or dairy, etc. But they have not taken into account the form in which foods are actually consumed. So processing level, for example, which has emerged as a new and novel dimension of diet quality, as it has been shown that the way foods are processed actually impacts their health effects, and that two foods of different processing level but similar nutrient composition actually have different health effects. And in my doctoral research, I demonstrated an association between ultra-processed foods, which are highly processed foods, I'll give you the definition in a minute, and both obesity and overweight, and cardiovascular disease incidence and mortality. So the objective of the current study was to determine the secular trends in dietary intake according to processing level from 2001 to 2018 across diverse sociodemographic strata. And we used NHANES 2001 to 2018 and had a sample size of over 44,000 adults. Next slide, please. So what we did was to classify all the food records in NHANES, everything that anybody consumed in NHANES, according to the NOVA framework. And the NOVA framework is a novel way to categorize foods according to the extent and purpose of processing. So I'm just going to quickly highlight the groups here. So unprocessed and minimally processed foods are what we think of as whole foods. Processed culinary ingredients are things we use to cook with, like salt, sugar, oils, etc. Processed foods include foods that have undergone some industrial processing but is free of additives and can be recognized as the whole food they come from. So for instance, canned vegetables and canned fish, or artisanal cheeses. Ultra processed foods are foods that have undergone substantial both physical and chemical processing and are mainly composed of starches, fats, oils, sweeteners, and different sorts of additives. So what we did was to calculate the proportion of calories in the US diet from each of these groups and assess trends over time. Next slide, please. So what we found was that accounting for changes in population characteristic or population composition, there was an increased intake of ultra-processed food from 2001 to 2018. It increased from accounting for 53.5% of calories to 57% of calories. So it's the majority of food in the American diet. And this increase was observed among all groups, with the exception of Hispanics, as you can see on the graph here, where ultra-processed foods are in purple. So the Hispanic population consume less ultra-processed food, and consumption did not increase over time. There was also no increase among college graduates and among those with an income below 130% of the federal poverty threshold. Otherwise, the consumption increased continuously in all groups. We also saw that there was a decreased intake of minimally processed foods in all the whole population and within each sociodemographic group, from on average 32.7% of the calories consumed to 27.4% of calories consumed. However, this decrease was primarily driven by decrease in dairy consumption and meat consumption, and thankfully there was a small increase in vegetable consumption. So that's something to be happy for. And I am currently in the wraps of submitting this paper for publication. I am very excited for when data for 2020 and 2021 is coming out, because we have seen some market reports that processed food consumption, ultra processed food consumption in particularly, has actually increased during the pandemic. So I'm excited to continue this research. Thank you very much.
Thank you very much. Thank you to all the speakers for holding to time. This is great. I'm gonna try to get our discussion going among the speakers with a few questions. I have to start, I want to start with Professor Angel, because you have been very visible. I think one of the classic characteristics of cities is the issue of density, and obviously there's anything that's overdone, I think, is a problem. But you've been
Joe, we can't see you or hear you. Oh, there you are.
Sorry, I cut myself off. I wanted to ask you a little bit about the pushback you might have been getting on your on a lot of your articles, because density has been a sort of one of the villains that's been hypothesized, at least in the spread of infectious disease in general and COVID specifically.
Yes, it's unfortunate that we're definitely seeing at least a temporary decline in density by people fleeing the central city and going to their second homes in the suburbs, or people buying homes in the suburbs. So what we're seeing is that great exodus into the city when it became safer in the 80s and 90s, and we could see increase in central city densities. We're now seeing the reverse trend, the kind of another white flight, the same as that we had 40 years ago. And there's a natural decline in density because of that, and because of more working from home, and it's going to be there. So people are voting with their feet. We can recommend densification, and we're trying to densify. After all, New York, since 1910, lost almost 1 million people. It used to be a lot, Manhattan used to be a lot denser. So there is pressure. What I was trying to do in my paper is differentiate the kind of densities that Constantine is talking about from average densities. Average density is what we care about when we're trying to look at the effect on the natural environment or on greenhouse gas emissions. Now, the greatest impact right now of the declining density is on public transit. Mm-hmm. And we're very worried that a lot of public transit companies are going to go bankrupt as a result of people being afraid to use public transit.
Thank you.
So we're on the defense, Joe. It's a very hard struggle.
Yeah, it's a really important issue at the policy level. And I just to pick up, I'm going to maybe ask a question that maybe Professor Kontokosta could take the first stab at, and then Emily, I want you to come in on this as well. You're talking about neighborhood level density of interactions sort of outside the home, and I think one of the epidemiological issues has been what's going on with crowding inside housing. I mean, that's been another issue. I was wondering if you could sort of hypothesize a little bit about how you might approach that challenge, but then link Emily in terms of this question of social cohesiveness resilience, because you're looking at higher interaction, outside the home in your work, and then Emily seeing that maybe there's a positive impact of that. I don't know if you're distinguishing, it's hard for you to distinguish between in-house and out-of-house, Emily, but maybe both of you could comment on that. Constantine, you want to start?
Sure, yeah, thanks. And I should begin also by acknowledging Lorna Thorpe and Arpit Gupta, who are collaborators on this work. But yeah, I mean, I think it's a hugely important issue. We were focused on thinking about questions of social distancing in terms of risk presented by those outside of the household. But certainly, we have the capability, and there's tremendous interest in kind of reversing that metric, essentially to begin looking at activity, changes in activity within residential buildings or within residential areas. So, there's certainly that potential from both a COVID perspective and then just more in general. I mean, how is overcrowding affecting different parts of different cities, and what are the implications of that overcrowding on a whole host of other kind of urban issues? So certainly something that's doable with the analysis that we have.
It's like super interesting to know about that inside the walls.
Mm-hmm.
Like, Emily?
I would say from a mental health perspective, that may indeed be protective. Though maybe not that crowding inside and even going outside the home, not for COVID risk, but indeed for mental health. We know that social isolation, for instance, has a very, very large negative impact on mental health. And so it's possible that the lower odds we're seeing in certain race ethnic groups in our study in terms of mental health indicators are due to that increased social support, but actually having really that support there, multi-generational households, larger households. Just to provide that support and social contact that we need very much for our mental health.
It's so interesting to look at this from the highest level to the neighborhood level to the personal level and the issues that get raised. It's one of the things that makes urban fascinating and urban health fascinating. So let me make sure I get a question to Niyati and Filippa. You both really talked about highly processed foods. I mean, we can obviously go into availability of healthy foods in the very communities that we've just finished talking about with our colleagues here, which we know is a problem. But I wondered if each of you might talk a little bit about, Niyati mentioned we're sort of trapped in this obesogenic environment, but there has been an increasing interest globally in the concept of commercial determinants of health. And I wanted you to just tell us a little bit about why you think that is, and then Filippa maybe come in on what policies might change the reality of the food environment in the United States. I mean, I think they're very connected questions. So Niyati, you want to start?
Yes, I think you're asking me the importance of commercial determinants or why it's increased in the global context. Yeah, I think this has everything to do with industrialization. It kind of started in Europe and the United States a few decades ago and catching on really quickly globally. Food companies specifically are looking at developing emerging markets where they can expand and quickly grow. That's one of the biggest reasons. And a good example is a place like Thailand, where they didn't have snacking. Snacking didn't really exist for them as a meal pattern, but the introduction of so many snack foods in the market has even changed how people eat, and they also want to mimic the West. So I think that globally we are seeing unhealthy patterns being duplicated from the Western world, and that's why it's a really big concern. And they also have, according to the WHO, rising NCD problem in conjunction with malnutrition, and eating and consuming these ultra processed foods actually increases malnutrition because they're deficient in many things, but yet makes them more obese and vulnerable to NCDs. Yes, so I'll let Filippa continue.
Yeah, thanks. Because I think one of we export a lot of things, and this is one of the set of bad habits here, I think. And Filippa, maybe what would you do about it in the United States? How might you begin to tackle this on a policy perspective?
Yes, so that's what I'm trying to figure out during my postdoc, because as Niyati said, these food companies have really pushed in emerging economies to increase their sales, and especially in Latin America have been very pioneering in developing policies to reduce the consumption of ultra-processed foods. It's including, of course, things like sugar-sweetened beverage taxes, but also actually incorporating processing level in national dietary guidelines and warning labels on food products that are high in sugar, salt, energy, etc. That has been very efficient in Chile, for instance. So there are different ways, and also restricting marketing to children. So one of the projects that I plan to do or have started during my postdoc is to look at the evidence for different policies, what kind of evidence exists, and also do an interview study to find out how these policies are working, how they were implemented in several Latin American countries, to see what lessons can be learned for the US context. I think a big issue here is that the food industry have a lot of financial power and thereby a lot of political power. So I think that is definitely a barrier to for policy options in the US.
Mm-hmm. That's great. Thank you so much. Pricing, obviously, in this kind of crisis too, I think they're cheaper. In some instances, really an issue. Let me go back to our first. I've lumped you together somewhat arbitrarily, but I wanted to talk a little bit about, I guess, the implications of maybe the sort of look at the density question at social cohesion. I mean, however what term one uses depends a lot of times on the discipline one's working from. But it's a really it's a challenge for how might you think about the work you're doing really to sort of support the importance of cities, that there's a editorial headline, cities are dying, et cetera. Sally, you started touching on that, but I think some of the advantages of cities, I'd be interested in you all talking, maybe all 4 or 5 of you really addressing that, but the 3 of you first, Alfred, how might you look at it from a research point of view? And then maybe we can have our colleagues in nutrition speak about that as well. And then I think we'll be at the end of our time, but it's just, there's so much we can talk about. It's really difficult. Sally, you want to get started, and then maybe the other 2 chime in?
Sure. Look, Jo, the cities by definition have been created and sustained by human contact and by close human contact. This is why they're so vulnerable to pandemics. And this is why also most of the innovations in public health come from cities, because they have to handle these pandemics. So I don't think there is an alternative to cities. And I think that we have to understand the challenges of living in close proximity to each other. But there's no question that the advantages outweigh the costs or the risks or the dangers. Mm-hmm. And for us, I think that we have to understand what I was trying to say before, that there are going to be cyclical patterns in terms of kind of getting close and getting further away. It's the same as relationships, you get close, you get further, you get close, and we have to kind of be patient with these patterns. We can't force ourselves on each other. We have to understand that sometimes we have to be further apart, and then we can get closer together.
Thanks. Constantine and Emily. Constantine, you want to go next, and then Emily?
Yeah, no, I mean, I think what's really exciting about what we're seeing now, and I think in many ways research around COVID has accelerated this, is the use of these types of geolocation data, which are kind of fraught with problems and do have significant kind of privacy issues that are associated with them. But when we account for those and address those head on, I mean, these data are just an unbelievable way to understand these kind of the dynamics of the city, right? The ballet of the sidewalk. I mean, it's really kind of critical and kind of thinking about how we could use these new resources and these new analytical tools to understand how these interactions actually play out. Because, historically we've been forced to use, very coarse survey data, census data, right? At best, it comes out every year. It's covering census tracts or some larger aggregations, but it doesn't give us really the kind of that pulse of the city in the same way that allows us to look at these differences for instance, at the neighborhood level, to really unpack the neighborhood effects and that black box of neighborhood effects that researchers have kind of struggled to really understand.
Yeah. Okay, Emily, real quick, and then I'm getting a prompt from Raquel to open it to the floor. So
yeah, absolutely agree. And I think, though I was looking on the individual level, one of the things that we like to do in the study is we have geocoding data for everyone in our survey. And though much more crude than what Constantine's talking about, we are able to connect people to their larger environment. And one of the things that we're interested in is how have cities handled the pandemic and how have they done it differently? So people in leadership, the communication, the different, sort of sheltering place orders versus openings and closing at different times, we're able to look at that and see its impact on other things besides this, including mental health.
Okay, thank you. My apologies to the audience. I got too carried away with the conversation. So Raquel, do you have some questions? I'm not seeing anything in the chat box. So were there others that had other members of the audience are invited, please to put your question in the chat box or send it in. Please, Stephen Graham.
Hi,
Turn
thank
off your
you.
mic. Yeah, go.
Yeah, just a quick one for Professor Angel on the density on COVID not really being a factor of dense cities. You mentioned urbanized areas, and is that sort of excluding the area where the metropolitan area ends, excluding the rural areas, or is there any kind of micro cleansing to get rid of, say, large uninhabited areas inside cities, like the Santa Monica Mountains in LA or Van Cortlandt Park or something that might distort the data?
You're on mute, Shlomo.
A quick answer, Graham. Metropolitan areas in the United States are defined by counties and by commuting patterns to the central city. So the counties include a lot of areas that are uninhabited. So the formation of these urbanized areas, which is a census, US Census definition, includes all the census tracts that have more than 1,000 people per square mile. So these are only the inhabited areas of the counties that constitute US metropolitan statistical areas.
Very good, thank you.
Any other questions from the audience? I'm going to ask then, while we're waiting, maybe we have time for one or two, but I'm going to ask Niyati and Filippa just to reflect a little bit on what might be your recommendations around improving the food supply and the quality of food in cities as such. I mean, obviously we're dependent on getting food into the city in the first place, but once it's here, could you just quickly perhaps comment on that? Niyati first and then Filippa?
Sure. Yeah, I was thinking about it as you asked. There's been a lot of two things. There's been a lot of initiatives that I'm aware of for urban gardening and urban gardeners. They actually have simple things like even growing food in tires, rubber tires, in old trucks and buses and cars. And you will not believe how many restaurants have actually hired urban gardeners to give them their organic and fresh food supply. And the other thing was something like what the state of Rhode Island has done, where cities have to have, it's a policy where they have to have about 25-30%, I'm not exactly sure what that proportion is, of foods coming from farms rather than big corporations. So something like that would shift the dynamic of.
No, that's a great policy move. That's important. Yeah, Filippa, comment?
Yes, I would definitely echo Niyati on local food production and also public procurement, that establishing that a certain percentage should be minimally processed and from local sources. Other than that, I would say pricing and accessibility is extremely important to make sure that healthy foods are available and accessible, but also affordable, because right now we know that highly processed foods or a diet on highly processed food is significantly cheaper than a diet of whole foods.
Right. Okay, I think we're at time now, so I don't see any more questions from the audience. Last chance, going once, going twice. Okay, let me just thank this really fascinating panel. I hope you all will start collaborating with each other even more than you may be already, because this would be amazing in terms of looking at these really important issues at multiple levels. So thank you so much for participating. And I think this room is open, and I'm being told this room is open until 2. Is where the doctoral posters will be on display, and we're asking everyone to stay and take a look. And I think the next session starts at 2 p.m. Safety, Education, and Resilience in this room. So again, thank you so much, Professor Angel, Kontokosta, Goldmann, Parekh, and Dr. Juul. So thanks very much.
Thank you.
Thank you. Thank you.
Yeah, so the work that I'm doing is in collaboration with Professor Ritzer from Langon and from Professor Porphyry from Tandon School of Engineering, and so the overall project spans over the topic of electronic travel aids for the visually impaired, which are high-level technologies that we can utilize to help the visually impaired to regain their mobility. And as you know, the visual impairment is is something that is becoming increasingly burdening for us, for our society, and is going to be a significant problem, especially in the future when there will be a significant aging of the population. And the current technologies that we have right now that are typically relies mainly on canes and guide dogs are not widely adopted. And what we're trying to do is to develop new technologies that we can utilize for the visually impaired to address the issue of mobility. So to regain a safe orientation and mobility. So the basic electronic travel aid that we are developing is based on a computer vision system that has a stereo camera that with a computer vision algorithm can recognize obstacles, and based on the position of the obstacles, as you see, for example, in this image, we can make the abdomen of the user vibrate, depending on the level of threat and the position of the obstacle. And this is in a spatiotopically preserved manner, so that they can recognize the obstacles very easily compared to other solutions that rely, for example, on bracelets and stimulation on other parts of the body. The main issue that you imagine that these devices are facing is that they require extensive testing to evaluate their performance and to be able to be deployed in real conditions. And also there are many different types of visual impairment stages that for which these ETAs can be more or less useful. And so in particular, in the early stage of the designs, doing experiments with these ETAs is can be very risky for the participants, and the recruiting can suffer from selection biases and may be challenging, especially in finding patients with different pathologies. And so our idea was to develop a virtual reality platform that can simulate visual impairment, and that we can utilize for testing of these electronic travel aids. And this platform can be utilized actually for different purposes, for this preliminary testing or for training of the visual impaired in utilizing these electronic travel aids, but also for outreach and disability awareness with the general public. And that's where we started for doing our simulations of visual impairment. And we are actually have a first idea with a first concept with 3 different visual impairments, and in particular age-related macular degeneration, diabetic retinopathy, and glaucoma. And we have first developed some disability awareness simulations and functional visual loss activities. In the first one, the users can explore a virtual environment with different types and severities of visual impairments. In the second one, they are required to perform an activity while progressively losing vision. And what we are currently working on is on interfacing this VR environment with the electronic travel aid. And we are planning on performing some experiments to assess the usability of this virtual environment for the testing of electronic travel aids, and to validate the efficacy of our electronic travel aid that we have developed for multiple visual impairments with different levels of severity.
Hi, everyone. My name is Jannie Gao. I'm a senior research associate at NYU C2 Smart University Transportation Center, funded by U.S. Department of Transportation. And I would like to just give a very quick introduction on our recent research about COVID, especially how our center developed an interactive data dashboard for visualizing COVID-19 impact for urban mobility and sociability. And one of the advantages of this data dashboard is that it tries to integrate numerous, open sources data in just one place, so that we can have a big picture of what's going on when we're monitoring the mobility trend. We have collected information in terms of vehicular traffic, transit ridership, citywide travel speed, freight traffic, as well as like risk indicators, such as reported crashes and the surge in speeding ticket. We also develop a sociability board, which is on the right side in the middle of the poster, that leverages hundreds of public traffic cameras and computer vision techniques to conduct real-time object detection for vehicles, pets, and cyclists, and also measure social distancing between pedestrian pairs using an unique reference-free distance optimization method. And by having this information for more than 100 locations that we collected, we're kind of like able to track social distancing and pedestrian density patterns at both disaggregated and aggregated level within the city. In addition, on the left bottom, as a part of the COVID-19 research, we also distributed a travel survey to look at how different population groups, especially for people with disabilities, old population, and low-income households were affected by the changes as a result of COVID-19. What we found is that the systemic inequity already exists before the pandemic, but the crisis kind of magnified these mobility disparities and produced new challenges. For example, people with disabilities are found to have limited alternative travel modes available to them when needed, and low-income households had to continue their commute on certain modes despite concern about using them. The preliminary results are presented in infographic on the left bottom. I know it's a little bit hard to see from the poster, but if you're interested in any of these research that are presented here, feel free to check out our dashboard, which the full link is on the right top of the poster. I think I can maybe copy paste the link into the chat box as well. So the infographic and the mobility board and sociability board or including some of the white papers that we develop are all on the dashboard. That's it. Thank you.